Hello, my name is Melanie Cavalier. I'm the Chief of Innovative Care Delivery at the Maryland Healthcare Commission, or MHCC. Welcome to another session of MHCC's Beyond the Textbook, Real World Medicine and Case Studies series, which is part of the MHCC Learning Network. Today's presenter will be Dr. Scott Fieser, Medical Director for the Johns Hopkins Care Transformation Organization. Today, Dr. Fieser will be presenting a project done to get patients more optimized pharmacology regimens. Thank you for presenting today. Please proceed.
And it's my pleasure. As said, I'm Scott Fieser. I'm a primary care doc within the Johns Hopkins system. And today I want to present this project whereby we were working to improve or optimize the regimen for congestive heart failure. And why did we pick that subject to take on? Well, as you can see here, and no surprise to probably anyone, heart failure is a leading cause of potentially avoidable utilization, and so a big opportunity. We had a team that I just wanted to at least list here briefly. There were certainly others involved, but I just want to give credit to the team who worked on this. We had PharmD, Max Ditluson, who was really key to the whole project, as well as expertise from Dr. Galotra, a cardiologist, and others as listed. So for those who are not clinicians, a brief explanation of heart failure and what we were attempting to accomplish. So heart failure really comes in sort of two varieties, broadly speaking. There's heart failure with reduced ejection fraction, where the heart doesn't squeeze as effectively. And then there's heart failure with preserved ejection fraction, where the heart squeezes well, but it doesn't relax as well. And in both cases, that creates problems where the blood is not pumped effectively and leads to a lot of downstream effects. So GDMT, or guideline-directed medical therapy, has been shown to be quite effective in improving outcomes for folks with heart failure. Those who have the reduced ejection fraction variety are well served when they are on 4 different medicines. And I've got some of the common brand names for those listed. But again, the idea is to get them on each of these 4 medicine classes and then optimize the dose of those medicines. The preserved ejection fraction has benefited from a number of different medicines, but in this project, we focused on the one which is has the most data showing benefit, which is the SGLT2 class of medicine. And why do we want to do this? Well, there's lots of literature now showing various benefits, both saving lives, adding reduced time or extended time before hospitalization, and reduced readmission rates. So clearly there's an opportunity if we can just improve the number of people who are on these medicines. And what we did was run a report for patients who were in the different sites who were participating in the MD-PCP program, followed by our CTO, although we also included patients at those sites who had other insurances where appropriate. And just looking at the patients with who had in their EMR, this is all done through Epic EMR, those who had an ICD code of I50.2, which is systolic heart failure, or that is the reduced ejection fraction heart failure. You can see the several hundred, well, it's about 1,100 patients total, hundreds at certain sites, but some patients at all the different sites. And so we started with that list of patients and then dug into whether they actually were in need of the medicines or adjustments to their medicines. I've listed here just those with systolic heart failure, but we also included those with preserved ejection fraction. In fact, the original list of patients was almost 6,000 with our first iteration, and then we trimmed that with some qualifications. So before we could implement this, though, we needed to work with, really engage the stakeholders to find out what folks were willing to have us do, because it's always a challenge to sort of impose the perspective of one group on the practitioners without getting their buy-in. So we started with some meetings where we engaged with both cardiology and with primary care and presented some of this data and talked about our plan. And the one thing that emerged was that the cardiologists felt it was important for them to be involved in making final decisions on medicine adjustments for patients who had the reduced ejection fraction heart failure. And primary care, there were concerns that some would be uncomfortable adding medicines for all patients with heart failure or adjusting these medicines, but they would be comfortable working with patients who had both preserved ejection fraction, heart failure, as well as diabetes, that combination, because the PCPs are already comfortable with prescribing the Jardiance and other SGLT medicine, and so felt that they would be willing to do that. So we developed the workflow, and as I sort of implied, we divided the patients into these two groups: those who had reduced ejection fraction, heart failure, and for those patients, our pharmacists reviewed the charts, pulled out patients who it didn't appear were either met criteria or were appropriate, and then sent messaging to the cardiologist with the recommended adjustments and scheduling with cardiology to get them back in, loop them back into care. These patients who we were reviewing, because we were just doing it from this spreadsheet report, were not exclusively patients who had just been admitted to the hospital. We were looking at patients actually who were out in the ambulatory setting and may have slipped through some cracks and had opportunities. So we had to get them back into care. And for those with heart failure, preserved ejection fraction, and diabetes, we focused on the routing the information to the primary care providers to adjust their medicines. Along with this, we developed some educational materials to help support primarily the primary care providers who had some less experience with GDMT. And this document created by one of our residents in internal medicine was very helpful and was forwarded to providers when we reached out to them. So there was a workflow, and I'm not going to go through the detailed workflow, but we went through extensive workflows to think through how our pharmacist would respond to all the different nuances of cases, because there's patients, sometimes they're already on optimized medicine, sometimes they're partially on it, sometimes they've seen a cardiologist recently, sometimes they haven't, and so we had to go through an extensive workflow, but this is not worth going into the details of right now. So how long has this been going on, and what's our timeline? We started thinking about this in the fall of 2023 and began those meetings to engage our stakeholders and get their perspectives. And then we developed some of the materials and the detailed strategies to begin in April of 24, pulling the data for all the sites, as I mentioned, and then beginning the chart reviews and outreach. We learned lessons, which I'll mention in a minute, with our early interventions, and through the summer of 24, we made some adjustments to the intervention. We also then, through this process, we're developing educational materials and developed an online educational module for GDMT, which was delivered in December of 24 to primary care providers. because we recognized that there was an educational gap, and also there was interest in this from PCPs, and they wanted to become engaged. And when they are feeling more knowledgeable, they're able to partner with us, with the cardiologist more effectively to identify those gaps, because oftentimes cardiologists would make a recommendation, but there would be some delay or something would happen, and it would fall through the cracks. And so having the PCPs knowledgeable and acting as backups is helpful. And then we completed our first run through all the patients in May of 25, and I'll present some data about this in a minute. So what were some of those mid-course adjustments? Well, we recognized we needed to find a way to make it efficient for our pharmacists to review charts and find those that were most likely to benefit from adjustments. Recognizing that we wouldn't be able to touch everybody, but if we could at least get the most likely to benefit touched, who had heart failure, that would be valuable. And so we restricted the heart failure with reduced ejection fraction to the patients. That should say less than, or I'm sorry, yeah, greater than 45 were excluded. And there's thinking that patients who have reduced ejection fraction, who then have a recovered ejection fraction that then does go above 40 or 45%, should continue on GDMT. However, to get buy-in from the clinicians, we felt it was best to just focus on those who continued to have a reduced ejection fraction. So we excluded those recovered ejection fraction patients, excluded those who were 85 and older. For the HFpEF, we limited it to patients who had a documented diagnosis of I50.3. There were a number of patients with our initial data poll who were listed as having heart failure with preserved ejection fraction, but for various reasons, sometimes that diagnosis wasn't as accurate. But when we restricted it to this particular ICD-10 class of diagnoses, we got more accurate list of those patients. We also had some PharmD residents supporting us in doing some of the screening. We also adjusted the communication we had through the EMR with the PCPs to make it clear that our pharmacists could reach out and really do the implementation for them, because sometimes the PCP said, yep, it seems like a good idea, but I'm not going to see them for another 3 months. And if you want to do it, please help me out and reach out to that patient. And then I also participated in sort of nudging for clinicians who hadn't responded to the messages within Epic. We've also then, as was mentioned, created this learning module, which was then implemented and presented in December to providers. It was not a required module, so not all PCPs have reviewed it and done it. There was also presentations we made with Dr. Galotra, our cardiology specialist, to the internal medicine and the family medicine quarterly meetings within our group. And then there are also, actually, this is a little dated, we actually did run a pilot for patients with preserved ejection fraction who were non-diabetic, and I'll mention that toward the end. So what were some of the results? So, and I'll get to this in the lessons learned, this is challenging. So we reviewed some 1,600 charts of patients and made recommendations. The numbers that are circled below, both for preserved ejection fraction, which was a recommendation to start SGLT2 inhibitor, 98 such patients were recommended to start a medicine. But when we looked at a review somewhat later, only 9 of those 98 had done it. Now, this data was pulled actually before there was any run out from some of this. So we expect in the next month, if we were to rerun this, it would be somewhat higher, but still, in this 10 to 20% range we expect. And then similarly on the right-hand side, you see the number of recommendations to start medicines, 45 in the ARNI class, 108 in the SGLT2 inhibitor class, and so on. But then when you look at the lower right corner, you see how many actually were implemented, and it was about 30 or so. And we particularly have used as one of our KPIs just the number of medicines that were added, because that's something we were able to pull effectively from the EMR, whereas identifying patients who had a titration and increase in their medicine doses, although that, we often made a recommendation to that effect, it was a little bit harder to see if that had been done. So we've just been tracking those who actually added the new medicines that were recommended as our KPI. So what are some of the next steps? Well, one of them is this pilot that I mentioned, which was run by one of our PharmD residents at a single site. They examined whether we could effectively increase the number of patients on an SGLT2 inhibitor who either do or do not have diabetes. And so some of the data presented here, basically there were 50 patients found to be eligible, and at the end of the day, 10 of them, or 20%, had started the new medicine. And then the barriers to initiation highlighted here. A lot of it was hesitancy from patients, some intolerance, some cost issues, and so on. But that big, factor of hesitancy. So if you're getting a call from a pharmacist who is not your lifelong provider, you may be hesitant, and plus just concerned about adding one more medicine. And so with this learning and what we've learned from the difficulty of engaging providers in general, we're planning a more opt-out approach with our next iteration of this project, where the pharmacist will identify specific opportunities for optimization. They'll notify the cardiologist and PCP of the plan changes, and then they will directly engage the patients, even if they haven't heard back unless the cardiologist or the PCP opt out, but they'll go ahead and proceed. And we're having very specific criteria for which medicines can be adjusted and what labs will be tracked and so on, and what exclusion criteria there will be. But it's going to be driven more by the pharmacist than just waiting for the PCP and cardiologist to respond and see the patient and do the implementation themselves. Now, as is suggested by the pilot that we ran, even doing that is going to be challenging. And so we're really trying to figure out the best way at this point to sort of have our cake and eat it too, meaning have the pharmacist primarily drive the intervention, but also engage the other physicians who the patient already has a trusting relationship with. So lessons learned, changing regimens of medicine really is challenging, and don't expect you're going to get a 50% or more improvement in these sorts of things. It's the guidelines are often not easily applicable to specific patients, and so it does make implementing these guidelines, these broad guidelines, makes it difficult in the reality of primary care and on the ground. So you do have to engage both patients and their trusted clinicians to boost the uptake of recommendations. Educating clinicians is valuable. It's a learning curve. Even though these guidelines have been out for a while, there's still a need for education of particularly primary care. And then having support of the ancillary team members certainly has been valuable. So there were clearly cases that we saw along the way where had we left it, the fact that the pharmacist could look for or could complete patient assistance program forms or other ways to make the medicine affordable, or could otherwise talk with the patient about what was going on. It was really valuable. So, it takes a whole team to be successful. So, and there's just references. So they're on the screen if you want to review. I'm not leaving it on too long, but I guess you can freeze the screen if you want to look anything up. So that's the completion of my talk.
So thank you so much, Dr. Fieser. This is a really interesting project that you guys did on optimizing these pharmacology regimens. And I think, some of those points that you bring to light about, it's sometimes people are very hesitant to change, and you do have to get several team members involved before this actually happens. And just like making the recommendation doesn't like flow through all the way to the end. So, I think that I love the data that you guys showed, and I think this is super interesting. So love to hear an update after you guys do your next phase to see if there's some changes in those numbers and that uptake. So this will be posted on the MHCC website, the Beyond the Textbook Real World Medicine and Case Studies. And we do offer other sessions on things such as improving patient satisfaction and diabetic care pathways.